Hello, I'm Dr. Bruce Nicholson. For the past 20 years, I've specialized in the treatment of patients with a wide variety of pain conditions. For generalists and specialists alike, one of our most important responsibilities is to help patients make analgesic choices that are both effective and safe. Most of your patients are making choices about OTC analgesics on a regular basis. Many may not know that there are differences between acetaminophen and NSAIDs, and that these differences may have important implications for their health. Let's review the mechanistic differences between acetaminophen and NSAIDs, differences that you may want to keep in mind when counseling your patients about OTC analgesics.
In the central nervous system, both acetaminophen and non-steroidal anti-inflammatory drugs, or NSAIDs, are thought to provide analgesia through inhibition of cyclooxygenase and the consequent reduction in prostaglandin synthesis, thereby elevating the pain threshold. At peripheral locations, NSAIDs also inhibit cyclooxygenase and reduce prostaglandin production. These peripheral actions account for their local analgesic effects, as well as for some of the unintended health consequences NSAIDs can potentially cause in the heart, stomach, and kidneys. Cyclooxygenase 1 plays a role in platelet function. Aspirin interaction with platelet COX-1 receptors mediates the cardioprotective benefits of aspirin therapy. In patients on such therapy, ibuprofen may compete with aspirin to occupy platelet COX-1 receptors, potentially compromising aspirin's cardioprotective benefits. In the stomach, cyclooxygenase 1 plays an important role in gastric mucosal protection. NSAID inhibition of COX-1 can diminish this COX-1-mediated protective mechanism. This can lead to GI side effects, such as irritation and bleeding. In fact, the second most common cause of peptic ulcers is regular use of NSAIDs. Cyclooxygenase 1 and cyclooxygenase 2 play a role in renal function. NSAIDs can affect both COX-1 and COX-2 in the kidneys. In people with some compromise of renal blood flow, NSAID inhibition of COX-1 in afferent renal arterioles can result in reduced renal perfusion. In distal tubules, NSAID inhibition of COX-2 can result in altered tubular sodium and water handling. In people with some degree of renal dysfunction, these effects can potentially further compromise renal function and promote fluid retention. The renal effects of NSAIDs may be more pronounced at prescription doses. Use of prescription NSAIDs in people on antihypertensive therapy may result in undesirable blood pressure elevation and a potential loss of blood pressure control.